I'm Dr. Prashant GARG, and I'm currently the chairman at LV Prasad Eye Institute. Welcome to this instruction course, which is titled Corneal Infections, When to Suspect Unusual Pathogens. I do not have any financial disclosures to make. I think we are all familiar with that the corneal infections occur much more often in low and mid-income countries as compared to most developed world. And it is estimated that probably the incidence is about 8 to 10 times higher than what is being reported from most of the Western world. And I think it is because of this high incidence of corneal infection that corneal ulceration at the beginning of this century was identified as a silent epidemic. And more recently,
He's not here.
how can that be? This is my laptop.
1 second.
We just checked also.
Yeah.
Okay. I'm sorry. So corneal infections occur much more often in the low and mid-income countries as compared to developed world, and therefore it is recognized as a silent epidemic. In addition, more recently, infectious corneal ulceration was proposed to be labeled as a neglected tropical disease status. Most of the time, corneal infections begin as simple corneal abrasions or are predisposed by contact lens wear. And from these simple events, they progress to frank ulceration and infiltration of cornea. But if you diagnose and treat these cases promptly, not only the infection resolves, but there is a lot of preservation of visual acuity. On the other hand, if we do not treat these cases promptly, they can lead to progressive worsening of the infiltrate, corneal perforation, and even loss of the eye. And therefore, timely institution of an appropriate antimicrobial therapy is very, very essential. The question that always remains is, can we treat all of these cases using a standard combination of drugs or standard therapy? The answer is obviously no, because all of these cases are caused by a wide variety of microorganisms, which not only include bacteria, but also include fungi, parasite, and microsporidia or some of the other difficult organisms. And therefore, it is very important that we diagnose these cases using an appropriate laboratory method or in vivo confocal microscopy. What I'll do is that I'll try to cover this talk of laboratory diagnosis, which was supposed to be given by my co-instructor, Dr. Savitri Sharma. She somehow was not able to come to this meeting, and therefore let me give you an overview of what are the different diagnostic strategies that we use in cases of ulcerative keratitis, discuss with you pros and cons of each of those diagnostic modality, and suggest how to make best use of each of those available options. I think if you look at a vast majority of the cases that come to us at a tertiary eye care center, these are treated empirically. And many a time, clinicians argue, no, I was having a definitive idea about what is the organism. It looked like fungal, and therefore I have started antifungal therapy. But since I need to provide coverage for concomitant bacterial infection, I have also added antibacterial therapy. And many a time, even antivirals are added. So this cocktail therapy is a very common way that patients are treated at a community level. Now, how good is this empirical method of diagnosing etiological agent? Yes, there are certain characteristic clinical signs that will help you arrive at a differential diagnosis. The advantages of this kind of methodology for picking up etiological diagnosis is there is no laboratory support needed, there are no additional costs if you are an experienced clinician and probably have a lot of experience in treating cases of corneal infection. And based on the epidemiology of that region, you may be correct and you will say, I am getting a high cure rate in my cases even without treating these patients empirically. But you must remember that there are no exclusive characteristic signs. There is considerable overlap of clinical features between different organisms. Number two, this kind of methodology of making etiological diagnosis is particularly challenging in geographical areas where fungal infections are as prevalent as bacterial infection, where the rare corneal infections are also common, and where the problem of antibiotic resistance is constantly increasing. In addition, if you give a combination of therapy, drug toxicity becomes another important region for non-resolving keratitis. I'll give you an example of this patient who was treated for close to 6 weeks before this patient came to us, was on multiple antibiotic as well as combination with antifungal agent. We did corneal scraping was negative, and what we did was that we stopped all the antimicrobial agents and started this patient on cycloplegics and topical lubricating drop. This was the response within first 10 days, and that made us sure that we are dealing with a keratitis medicamentosa. And then finally, this patient progressed to complete resolution in 4 weeks with significant preservation of visual acuity. There are publications that have looked at clinicians' ability to distinguish between bacterial and fungal keratitis, and they found that other than feathery hyphate edges, there were no other clinical signs that were not overlapping between bacterial and fungal infections. And therefore, you will find that the literature strongly advocates that ophthalmologists must do microbiology workup in order to identify the causative organism and start treatment based on the microscopy and culture and sensitivity results. So in our view, empirical therapy, if at all being practiced, should be used only for small ulcers. Ulcers which are 2 millimeter or so have less risk of threatening the visual axis, and where the clinical signs of fungal and acanthamoeba are missing. In those cases, you can start therapy only with antibiotic and call these patients at 48 to 72 hours to understand what is the response to therapy in these patients. The patients which are larger than 2 millimeter or are having infiltrate encroaching on the central cornea or have significant thinning must undergo a detailed microbiology workup, and the treatment should be based on the microbiology workup. If you do not have the facility of microbiology or managing these cases, it is better to refer them to higher centers sooner than later. So what is a classical microbiology protocol that we follow? We use the corneal scraping either using the 15 number surgical blade. You can use even Kimura as a spatula or even the calcium alginate swab. The sample so collected is smeared on pre-sterilized clean glass slides for gram stain, Giemsa stain, and is also used for potassium hydroxide chalcofluor white. It is directly inoculated on culture media that facilitate growth of bacteria, fungi, as well as parasite. And wherever the facility for PCR is available, you can also use phosphate buffer saline to preserve the sample for DNA extraction and subsequent PCR. The advantage of this kind of microbiology workup is you can visualize organism directly on microscopy and immediately start treatment based on the microscopic examination. The organisms will grow on the culture plate and you can identify these organisms based on biochemical reaction. You can even perform antibiotic susceptibility test, and this methodology also help you identify some of the rare organisms which we will be talking in today's course. However, you have to realize as a microbiologist, as a ophthalmologist, many of us do not have very well equipped laboratory. And even if you have the laboratory, you will require help of a trained microbiologist in order to process all of these samples. There are additional costs, and corneal infections occur in mostly low socioeconomic strata, may not be able to afford. And then there are issues around the sensitivity and specificity. A negative microbiology does not mean there are no organisms. Whereas there are certain organisms, if they are present in the microscopy, you are definitively sure that your case is caused by a particular etiological agent. So what can you do if you do not have microbiology laboratory support? I think a simple bimicroscope with potassium hydroxide can help you distinguish fungal from non-fungal infections and may help you start appropriate therapy. In addition, what we found recently is that trypan blue-based staining method delineate fungal filament as well as parasite much more clearly, and therefore will enhance your ability to pick up these organisms. The second method that we use commonly to identify causative organisms is corneal biopsy, particularly in patients where the infiltrates are deep and corneal scraping is unlikely to result in any. In these cases, you can raise a flap and then take a deeper scraping or even remove a section of the tissue which will help you identify the causative microorganism. Here the advantages are that you have a larger tissue sample which can be processed not just for microbiology but also gives you histopathology. It also helps identify organisms which are either slow in growth or are difficult to grow, particularly the Mycobacterium tuberculosis. And at times it helps debulking of the tissue and resolution of the infiltrate. On the other hand, it is an invasive procedure. You are removing a tissue and therefore there will be resultant scarring, irregular astigmatism. And here again you have variable positivity rate. It is not that the sample that you have taken show you the microorganisms. In our at our center, the first diagnosis of microsporidial stromal keratitis was made because we did biopsy from this patient who was having central infiltrate, and repeated corneal scraping were not able to give us a diagnosis. So we did a penetrating keratoplasty, excised tissue was examined microscopically, and we found. Similarly, in this patient, in the interface following post-LASIK infection, the flap was amputated because it was already necrotic, and this flap showed multiple acid-fast bacilli, and the diagnosis of atypical mycobacteria was made. Confocal microscopy is another method of making diagnosis. It is rapid, repeatable, non-invasive examination technique and gives you in-clinic diagnosis. The pros for confocal microscopy are that it is a rapid in-clinic test, give you prompt treatment initiation, help assess the depth of the infection, and also can be repeated to assess the response to treatment. However, you have to remember that except for fungal and acanthamoeba keratitis, the sensitivity of this test is relatively low. It also requires patients' cooperation to pick up good images, and the interpretations are usually dependent upon the person who is performing test and its experience. Further, the tool is more expensive and not available to all. So for us, the indication for confocal microscopy are where the microbiology is negative and there is a strong suspicion of fungal and acanthamoeba keratitis, where the infiltrates are deep-seated, and we also use this modality to monitor treatment response at our center. A word about molecular diagnosis. They are becoming more and more popular. The samples are subjected to DNA extraction, which is then processed either through standard or conventional PCR or through RT-PCR in order to identify the genes which are very characteristic with particular organism. Now there are wide variety of diagnostic tests which are based on molecular methods. Each of these tests have their pros and cons. The most important thing is that while they are allowing you to pick up microorganism within 4 to 8 hours, they also involve additional cost, and many of the centers may not have possibility of these machines being available, and therefore these tests have still not become very popular. But in the times to come, I'm sure these tests availability is improving as well as the cost is reducing, and they are going to take a bigger role as far as diagnostic microbiology is concerned. For us, this test has been very useful. While doing fungal PCR for organisms which we could not identify because of the lack of sporulation, we did DNA extraction and looked at, and we were able to identify Pythium insidiosum because of the molecular diagnostic test, and then establish a methodology to identify that using routine microbiology workup. So in summary, there are numerous new diagnostic tools that are under development. However, as of today, conventional microbiology continues to be a gold standard. And the future for rapid identification of microorganism remains bright, particularly when we are talking about rare organisms. And in today's instruction course, the molecular methods are going to be playing an important role. With that, I'll like to end the first part of this course, which is more around the diagnostic microbiology. And I'd like to invite if there are any questions before I switch over to my talk on antimicrobial resistance. Amrita, you can set up your talk on that side. Next, you can take that. Are there any questions? Yeah. I'm not able to hear you.
I was just asking how much is your culture result positivity rate?
Yeah, so the culture positivity rate is roughly about 60%. And I think and that too is primarily because we have a lot of fungal infection. But if you talk about pure bacterial infection, it is even lower than that.
And would your microbiologist tell you for example, this is the general, to what extent will they go further? Do they test to be very specific to the actual organism?
Yes, they are able to, because they are using the YTEC method, which is able to give you using a chain of what you call as a biochemical reaction, you can narrow down to certain level. And we also have started doing PCR for identification, which is helping us distinguish.
Also the PCR, they usually tell us, you can go and give 16S or 18S, pretty much that's it. And to actually have more diagnostic ability, then it will be costing so much more.
Yes, so it is sparingly used. It is not that for example, currently we are running a project on fungal pathogens. And we are not just saying it is Fusarium or Aspergillus. They are able to give us more specific diagnosis to the species level.
Just to reinforce the point you made at the very beginning, we did a study and subsequently published it on site-threatening corneal ulcers that were admitted for inpatient treatment. And after taking the scrapes and everything else, we then start treatment straight away. And the standard we have is 1 aminoglycoside and 1 cephalosporin intensive treatment. What we found was that those that were culture positive and those that were culture negative, there was no difference in the outcome
Yes.
of their treatment. Equal number failed, equal number succeeded. So it tells you that just getting a positive culture is not the end of everything. You can empirically start and still have a.
Yeah. Can we show the?
Can I ask you a question too? We often encounter the patient with severe corneal ulcer that all the results were negative, even though with the in vivo microscopy. Do you have any, in your practice, do you normally reduce, like try the antimicrobial one by one and challenging, or you like start all the medication and see the response?
I usually stop all the medication and assess the patient in 24 hours to understand how the clinical picture is.
Even though if it results still negative and then it progress, so you're going to challenge the antimicrobial one by one, not like.
No, I don't think so that you should just keep challenging by giving empirically. I think non-healing or culture negative corneal ulcer pose a very, very different challenge. And although we are not covering it here, but we have found that in these patients, if you stop drugs and then culture them again after say 48 hours, you are likely to get a good yield. And you will, at times, you will be able to differentiate keratitis medicamentosa from other frank corneal infections.
All right, thank you so much. Do you have any experience with the corneal impression membrane that proposed by the group in the UK that they say that when you stamped the papers on the cornea instead of the scraping, the result is quite similar, but
I don't think so that by just putting a impression cytology, you will get enough organism.